ascendi on the left-hand side.
Slightly to the left, right?
Slightly to the right. It seems to be peripherally enhancing, but incompletely enhancing.
Right.
There's no significant mass effect. It doesn't appear as though the fourth ventricle is dilated or the lateral ventricles are dilated.
And I could tell you there was no edema.
Okay.
And it did have, there was one that showed some signal voids, suggesting that it was vascular in nature. Anyways, that prompted an angiogram. See, because hey, there was question of prominent vascular structures. Okay. Oh, she had a CT angio first. I think that's the way the story went. She had a CT angio first. No reconstructions. So there was something, that's what prompted the angio. There was something in the PICA territory, okay?
Looks like there's some calcification or something.
It's important to see the non-contrast. I don't know if there's a non-contrast here. No, it's all contrast. But it does look like calcification that made it highly suggestive. Now you see it just vascular, right? So the guy got an angiogram. I'm gonna do something a little different, and we're gonna go over, which I think they did very good. Okay, and we're gonna do this one also too. Okay, so this one also 2 and 1. Okay. So this is the lateral and AP. And there was obviously this peculiar, you can try to describe it. We can put that there and we can put this one here. And then peculiar, right? Just describe it with your own words. And you can ask for another view, or something.
So in the region of interest correlating with the MRI, there's abnormal vasculature, which appears to arise from the right posterior inferior cerebellar artery. Although I'm not sure if there's some meningeal supply as well. The artery itself appears dysplastic. It's sort of multifocal fusiform and saccular dilatation.
I mean, how would you call this structure like that? Let's go and see. They did another view. They obviously did the first AP and lateral, and then they did the opposite vert, right? So here is, it's a good way, the lesion is coming off the left pica. So they did this. By the way, do you know who this is?
It's the branch to the dentine arcade.
We have to decide what this artery is. Do you know what this artery is? Anterior spinal. Good way is to look at the lateral. Okay, if it projects anterior, anything projects anterior to the vertebral is going to be part of the ascending system. This one also seems to follow, it will anastomose with the one on the other side.
Yeah, the dens arcade.
The odontoid process. It's got something here, I don't know exactly, but there is some schmutz there. Yeah. Okay, but if we analyze this, what would you call this? Let's take one at a time. What do you call this thing?
That looks to be a saccular aneurysm.
It's like an aneurysm, right? And then you have another one here. Yeah. It looks like another aneurysm. And then you got a whole bunch of these things that looks like multiple aneurysms. But in addition to that, there are channels, right? I mean, I have one artery here, one artery there, right?
Yeah.
So as soon as you see that, the next question is there an early draining vein, right? We don't see any. Now, the nice thing about they did is that I'm going to try to put here the lateral of the left side injection. Okay, so you see better that it is coming from the left pica. Okay. Let's see the AP. Sorry, no, this is the right word, but it's coming from the left pica. I think they did the left vert too. Anyway, so they continued the workup, and the carotids were fine. This is just for billing. There was nothing in the carotid system. It's important when you see something weird like this to look at the carotid, see if there is a systemic disease or there is a focal problem, right? You already see that this lady has, look at the artery, how, like we see sometimes with hypertensive people, right? There is no real FMD, but it's kind of things that should come to your mind, okay? She's a young woman, she's in her 30s. And then they went to the left vertebral. So what would you do next? You know what? Okay, so it's something unusual. There's no AV shunting, right? And then we know the segments of the pica. Anyone?
Anterior medullary is the first segment.
Yes.
Lateral medullary.
And what is important of all this segment? What
supplies it gives supply to the brainstem.
Yes, it's perforators. It's very important perforators. Okay, so it's important where it goes. Okay, this is the tonsil, the tonsillar segment, choroid point, right? Okay, so that's now we need to understand exactly where that is. But it's relatively proximal. And you see how there are more than one vessel, right? There's more than one channel, let's put it that way. And it goes all the way there. What could you do to try to work this thing better?
Do selective.
You do obliques.
Okay.
Today, obliques were you can do 3D and it's just going to be the same, prettier. What can you do to try to answer the question? Question number one is, what is it, right? Question number two, where is it? Question number three is something definitely strange. What is the territory it supplies? Because if I'm saying one of the treatment is I close this artery, right? So can the patient tolerate? And how do I figure that out? How do we do that? Any ideas?
To get a better understanding of the specific location.
The location is good because the MRI is better than angio to tell you.
MRI, yeah.
No, it's something unusual, something different, something unconventional. Right? What would you do? You're the attending of the day.
To see what deficits you'd create if you sacrifice the vessel, you mean?
Yeah, I mean, whatever this is a dysplastic segment with aneurysmal ectasias. I actually think this could have been a recanalized channel that has vasa. So there could have been, but we don't see in the MR like a pre-existing aneurysm with like those fusiforms that you see in the MCA that have funding channel. But I think it's a dangerous lesion. This can rupture. This can create trouble. So one of the things, first I need to understand it better, but yes, sacrificing the vessel. I can't imagine you're going to clip this. I can't imagine you're going to coil this, right?
Yeah, there's multiple.
Okay, so what do we have today? This is a selective left vertebral, right vertebral. What's the next step? You got microcatheters.
Right, selective.
Why don't we do a super selective injection? I don't get any overlapping, and I get a better idea. They did a great job. This is Dr. Howard Rena, one of my friends in NYU. So he went ahead and did a selective PICA injection. Okay, and it does help. Okay. So you can see here the catheter is proximal here, right? Definitely this we cannot sacrifice. It shows this segment is normal, right? As we come in this, there comes the bizarre. Indeed, there is this bubble. There's another little bubble there. There is a funny channel here, another channel with that. And then I pick up normal vessel up here. Okay? And I look at this vessel. It's a fair size territory. It's a fair size territory, right? What territory is this? Tissue-wise. What is this? It's not brainstem.
It's like a
cerebellar hemisphere. So a stroke here is not so terrible. It's better not to have it, but it's not so terrible. So okay, so now I get a better idea. Definitely this is a dysplastic segment. Look at this sausage here, right? So I know that I cannot super selectively catheterize this thing to go coil each one of them. So what can be done? And how do I work it out? What are the options?
I think liquid embolics would be the only thing you'd be able to use to take out
Okay.
the entire lesion.
Liquid embolics, but how do I put it? Where do I put it? How do I predict if I'm going to give her a cerebellar stroke or not? How can I work those things out? Because I can do a bypass too. PICA bypass, and then sacrifice the segment. Have you guys seen or know about the PICA anastomosis? The PICA anastomosis is the tonsillar segment. The PICA, as you see in this is an AP view. This thing comes here. The other PICA would come here. So the side-to-side anastomosis is done in the midline from the tonsillar segment. Unfortunately, the lesion here is distal to it. So the only way to do a bypass would be into this branch, which now is more difficult, and you gotta transposition all that. So it's problematic. So now I could go surgically clip here. Not good. Not good. So I need to do some more workup. What would you do next for working up this? This has to go. We need to make it how best to do it, how less invasive and secure. Any ideas? Let's see what else he did. Okay, so he went more selective. Okay? See, there's also this anterior branch. This. So there is a lot of real estate here that could be problematic. So what else can we do? You take a balloon catheter. Look, bizarre lesion, eh? So you take a balloon catheter, septor. So here's a septor. Okay. And then you inject here the injective vertebra. What's going on here? How did this thing segment feel?
It's a collateral from the AICA.
No.
Or the
I knew you'll say that. This hasn't reached here.
Oh yeah, the blade's not occluse.
What happened? No, they did a bolus, but this is going around the catheter, you see?
Not occluse.
And feeling it. But it is producing some decrease in flow. So I think the next thing he did is to actually inflate the balloon. Let me see. No, the balloon is still not inflated. Maybe the balloon is inflated. Yeah, there is a.
Oh, I see.
Yeah.
It's right at the
Yeah,
bend
but it's
the
still
vessel.
leaking. It's still leaking. So I think he did. I did see the. So you have to slowly do this gently. Okay, so here's the balloon. Okay, so still not. Maybe injecting a little bit at the tip. I think there was one where the balloon was well inflated. Yeah, this is well inflated. Okay, this is, yeah, this is gonna be here. This go with it here. The balloon is inflated there. Okay, so now we don't feel anything. However, there is some collaterals that come into some of this. Right? This is part of the complex. Okay, so now with this balloon, how do we know that we can sacrifice the artery safely?
Well, you just compare it to the initial microcatheter angiograms to the capillary phase to see how
Very
much of a
good.
defect you're going to have.
So that's what we're going to do now. Let's see the A. There. Okay. So can you tell me if you can sacrifice? It's in the answer is in the pictures. Remember what I said when you don't know what you're dealing, you go from distal backwards?
Okay.
It's okay. So distally I have this Y. You see this Y here? Okay? You see the Y?
Mm-hmm.
Yeah.
Yes.
This picture by itself tells me there will be no problem sacrificing this artery. Couple of things also. While you're doing this balloon, one other thing they could have done, I don't know if they did or not, although Howard probably did because, you know, he trained with me. What you do is you have the balloon now. Now I inject the PICA and I come all the way to that upper part and I stop injecting and I see washout.
Oh, right, okay, yeah.
You got, I'm blocking this thing here. There is collaterals like this. So I inject, and the moment it gets to the collaterals, I will see washout of my contrast. That would be an assurance that there is flow. Make sense?
Rather than having.
Okay, so now we've determined that number one, that we can sacrifice this. I mean, there is always if you throw emboli, it's going to be problematic. So that's going to be the key. So now comes how are we going to treat this thing? So I'm going to put, okay, any questions with this? Agree?
Makes sense so far. Yeah.
Okay. So now here is the segment we're trying to close. We've determined that we can have collateral circulation coming backwards this way. So if you ligate it here,
It will stay open.
it says the possibility of getting resupply in. And now once you close this, you have no access to it. So what are my options?
Well, you need to completely penetrate the lesion if you're going to use a glue embolic, so you don't do a ligational embolization.
Okay, so you want to penetrate. You want to use a liquid embolic. Okay, question which one and how would you inject it? What are the dangers of the liquid embolic? Control.
So glue, obviously, the dilutional component of the glue will determine how quickly it sets. You can't have a glue that you inject that will set too quickly.
Glue
otherwise-
could work, but it's not. It's a hit or miss. I want to make. I can't reflux. I know that if I reflux, this segment has a lot of very important, non-forgiving
Onyx with
arteries.
like
Sorry?
You could do like onyx with a scepter or something.
Yes,
Block.
yes. You can also do surgery. You can clip here and clip there.
Right.
It's possible, but you got to open the head. So that's exactly what I would do, is put a scepter or a mini scepter here to prevent reflux. And then you put the mini scepter here, you inflate it, and then you use contrast material, and you see that you have full control, that nothing would wash the onyx. And remember, all you need to do is close it here. So you got this safety segment. This same,
When you
when you have the
start
balloon,
seeing
you
it
just
go-
go very gently with the onyx. Go on, 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 go on. When it starts on feeling, that's when you stop. You wait a minute or two. Let it hurt. And then because you have not felt completely this. but you don't need to make 100% cast. So I think that that's the safest way, and we have evidence that she can tolerate it. Nice case, huh?
Yeah. What do you think caused this? Is
That
it
I
some
don't know.
kind of revascularization?
She has no history of any trauma. She has no history of anything.
Yeah, that's very true.
When you think you've seen it all, you know, something else come up. Okay, so any questions on this? I love it. I think it's a terrific case. We'll do it. I'm going to call it today.